Well, hello, everyone, and thank you for joining us today. We appreciate you tuning in. I want to give a special hello to all the World Affairs Council members. We hope you and your families are well, and thank you for your faithfulness to the Council and its mission to promote global education. I am Marianne Maldonado, the CEO of the World Affairs Council of Greater Houston, and I welcome all of you today to our program. Our conversation today is with Dr. Peter Hotez. Dr. Hotez will be discussing the COVID-19 outbreak and his lab's important work in developing a vaccine. Now, more than ever, it's important to stay informed about what's happening, not only in our city, but around the world. And I invite you to join our weekly conversations here on this YouTube channel. We upload programs often, so be sure to click the red subscribe button to receive our latest conversations in your email inbox. And for those who are new to the Council, you can find a listing of all our upcoming programs and activities on our website at wachouston.org. Additionally, we've just announced our Global Scholars Academy, and applications are now being accepted. This is an in-person summer program open to middle and high school students who have a passion for international affairs. So if you know of a student who is interested, please visit our website for more information and to apply. Everyone's welcome and scholarships are available. Now, joined by the Council's own Ronan OMalley, it's my pleasure to introduce to you Dr. Peter Hotez, Professor and Dean of the National School of Tropical Medicine at the Baylor College of Medicine, and co-director of the Texas Children's Hospital Center for Vaccine Development. Dr. Hotez, it's a pleasure having you with us again.
Thanks so much for having me. Great to be here.
And thank you very much, Marianne. As Marianne mentioned, I'm Ronan OMalley. I'm the Director of Programs for World Affairs Council of Greater Houston. And I'm delighted to have a longtime, not just speaker, but good friend of the council, Dr. Peter Hotez. We're so fortunate in Houston to have one of the world's most renowned vaccine researchers and infectious disease experts. So many titles, including former, one of the few U.S., appointed U.S. science envoys to represent the nation in our kind of soft power exercises of spreading global health diplomacy around the world. Dr. Hotez, you've covered a large variety of topics for us. Thank you again. Not just are you one of our most frequent speakers, you're also one of our most popular. You've spoken on a wide variety of topics to our members in different years, from everything Ebola outbreaks to Zika, when that was flaring up, to advancements in global health, to I think the last event was with regards to concerns about declines in vaccination rates in the United States and other parts of the world. But before we get into maybe a discussion of vaccines and where we might be looking for down the line with regards to COVID-19, is it fair to say if we're starting here today that for the scientific community has only had roughly 4 months to understand what's happening or even get an idea of what's happening in regards to COVID-19? So what has been put out or what may have been believed to be true at one point may have changed or had been updated at that point. And even what we believe to be true now in time might need to be changed or updated.
Well, thanks so much, Ronan, for having me, and it's good to be with you. Unfortunately, we seem to only talk whenever there's a crisis.
Yes.
So that if you know the two of us are talking in public, something bad's happening, and here we are yet again. So that's right. So we just found out about this pathogen in January. It's really amazing if you think about it. We didn't even know it existed up until a few months ago. I found out about it because I had heard that something was happening in China, and the Chinese were putting up a lot of scientific information on a preprint server that anybody can look at. It's published by Cold Spring Harbor Labs, and the Chinese were putting all the information out there. It's called bioRxiv, spelled BIORXIV, and that's the first thing. That and medRxiv are usually the first things I check in the morning. And back in middle of January, there it was, that it was a coronavirus, and it had some similarities, not the same, but some similarities to what was called SARS, severe acute respiratory syndrome, the same virus that emerged out of China in 2003. It was about 80% similar in the genetic code. So they had isolated the virus, they'd gotten the genetic code, they'd showed it bind to the same host receptor in the lungs and other tissues called the ACE2 receptor. And I said, oh my God, we're in for a ride, because I knew how bad SARS and MERS was, and activated a number of things because we had had a coronavirus vaccine program for the last decade. But then the scariest part was slowly the story unfolded about how transmissible it was, and how rapidly it was spreading to the community. And that was different from SARS or MERS, SARS in 2003, MERS in 2012, because those two viruses, if you were sick, if you got it, you were so sick that you went into the hospital. And so there wasn't much time to transmit it. So that the number of cases of SARS never topped 8,000 globally. This one was different. It was kind of a two-pronged virus. There was one subset that was getting very sick and was going into intensive care units, and another subset of people that handled the virus pretty well, and they were not very sick. And in some cases, they had no symptoms at all, and they were walking around spreading the virus. And that I knew was going to be something unusual and something devastating, because it meant that this was going to travel widely. So by, I can't remember the day, January 20th, January 23rd, I knew we were deep in it. We were going to have a major problem, and it's been off to the races ever since.
And from the scientific community's perspective, can you explain why it is important to be able to trace, if possible, where a virus actually emerged and maybe how it emerged? And I guess, can you let us know at least what we believe to be the case as to how this virus emerged? We've heard about maybe it was a wet market, animal to animal transmission, and then to a human in Wuhan, or what do we know about that, and what do we believe to know?
Well, nobody really cared much about coronaviruses before the 21st century. So we knew they were causes of upper respiratory infections, occasionally caused severe pneumonias, but generally they were of modest interest. They were considered one of the important causes of the common cold, but not as common as some others like rhinovirus. No, they were kind of, if I were to lecture to the medical students about it, it would be at the end of a longer lecture on upper respiratory infections than just to check the box. I would talk about coronaviruses, and then in 2003, everything changed with that new one, and that stimulated a lot of research. And one of the findings over the last 2 decades, since the first one emerged, serious pandemic emerged, is that they circulate in bats, and they are natural viruses of bats. And this is not the only virus. It turns out lots of viruses affect bats. In fact, Ebola virus, which is a very different virus from the coronavirus, also comes from bats, as does Nipah and a few else. So, why we're seeing more human infections now is there an encroachment from human habitats into previously forested or uninhabited areas as the population expands. That's one of the theories why Ebola emerged out of DR Congo in 1976. In fact, I was invited to testify to the House Science Committee, House Science, Space and Technology, and seated next to me was Dr. Murray, who's actually from the Smithsonian, where they have a whole bat virus program. So that's how far things have evolved, both in terms of the virus and the study of the science.
And in terms of developing a vaccine, is it important to try to confirm the zoological origins of a virus, which animals might have come from, or is that necessary?
Well, it's not so necessary in the strict sense in terms of developing the COVID-19 vaccine. It doesn't really matter. But what does matter is, I think, one of the fallouts of this epidemic in the coming years is people are now finally going to take coronaviruses seriously. We started certainly taking them seriously when we started our coronavirus vaccine program a decade ago. And I've been saying, we need to take coronaviruses as seriously as influenza. And by that, I mean we have very detailed surveillance programs, and we have this carefully orchestrated dance to make a new influenza vaccine every year. And so it's a major part of our global surveillance ever since the Bush administration. There was a group of scientists that whispered in President Bush's ear about H5N1 and avian flu, and he got very worried, and he made that part of his daily briefings. And that's why there has been so much attention about influenza over the last 2 decades. And I think now we'll probably see the same for coronaviruses, and we'll have to build up that global infrastructure for doing surveillance and having multiple vaccines ready to all of the different strains. Because look, I mean, because we couldn't get that few $1 million investment in vaccines 10 years ago that we needed, or a few years ago, what's the hit to the global economy now? At trillions, measured in the trillions. So huge. So the point is, we're slowly getting it in terms of the fact that these emerging viruses are not only public health threats, they're huge economic threats and now global security threats. And if you remember, you had me talk to the World Affairs Council about one of the books I had written called Blue Marble Health, about how these viruses, how these diseases are disproportionately affecting the G20 economies. And so even though they represent 86% of the global economy, they also account for most of the world's neglected and emerging infections, especially the poor among the G20 countries. And we spoke about the need for a G20 summit to build global health technologies for these diseases. I look back at that book. It came out in 2016. I think I spoke to the World Affairs Council then about the book. And, I have it published by an academic publisher, Johns Hopkins University Press. And the World Affairs Council stimulated some interest. But, boy, it was pretty much the case. And now Johns Hopkins Press, I think in the next week or so, is going to issue what they call an instant book version, and I added a COVID-19 chapter to it, so that should be out.
That's good, and I want to now move to kind of where we are with the virus itself, and I suppose what we know, but maybe it's the last question related to its origins. Especially, at the end we might talk about the future of pandemics, and others are going to come. But it's concerning to the medical community that perhaps this emerged in November. We don't know exactly when, but for certain in December, people in China knew about it. Sadly, some of the people who tried to make people aware of it, there was a young, I think just 34-year-old doctor, Dr. Li Wenliang, who just in a private group with physicians, he mentioned to his group of friends who were doctors that this is something that reminds me of SARS. His voice and others were repressed. He was forced to publicly sign a letter of apology and for disturbing the public order. Are you concerned for not as much now, but the future of a next pandemic and what comes out? Some of these have come out of China. That what is most crucial to the medical community is time, perhaps. And if the Chinese government continues to repress information or not give accurate statistics, that it makes the threat of a pandemic that much bigger and also that much harder for the medical community globally to handle.
Yeah, the story, I think ultimately is going to come out to be a little bit nuanced. I know right now China is being heavily demonized by the White House, and even they go kind of hot and cold with China. You see the president talk about what a great call he had with President Xi and that side of things. So there's clearly some ambivalence there. From my perspective, seeing that the Chinese were really putting everything out on bioRxiv, so I wasn't really paying much attention before January. And my understanding is the timeline looks like this. They first reported the virus to the World Health Organization on December 31st. And so the WHO, the World Health Organization, was aware of it by January 1. By the middle of January, the Chinese were putting up all of the information about the virus in bioRxiv. It was very impressive to see how quickly their scientific infrastructure was putting out information about the virus. I say that because when SARS started in 2003, it took a year to get all that information. Now it was coming out within weeks. So within weeks, we knew what the virus was, the genetic code, the receptor was binding to. We knew we had a viable vaccine strategy. So that part was pretty impressive. So among the scientists and I think the doctors, there was a fair bit of transparency. And I think we're going to have to do some type of investigation to figure out how much the leadership covered it up in those first few weeks. I just don't have a sense of it. And everything is so heated politically now. It's tough to really know this. And I think, one of the things I've been doing a lot is going on, in addition to making our vaccine, because we've had that expertise of coronaviruses and other neglected and emerging infections, I've been asked to go on the CNN and MSNBC and Fox News, and it's been a real honor to speak to the nation. And by the way, it's not easy going from MSNBC to Fox News to CNN. You can imagine that needle has been interesting. But one of the things, and again, each of those cable networks is pretty politically revved up, and try not to fall in. I try to do my best to avoid those traps, and particularly when I'm asked, is there a cover up, whether it's from China or the World Health Organization or the White House, and I say, look, right now's not the time to be exploring this. Right now, it's all hands on deck to save lives and to get this pandemic under control and advance technologies. Eventually, who knows, there may be something equivalent to a 9/11 commission or something along those lines. And then, we'll figure out what went wrong. And by the way, things always go wrong in the beginning of a pandemic. I saw this with anthrax in 2001, with SARS in 2003, with MERS in 2012. I saw terrible mistakes made with Ebola in West Africa in 2014, with Zika. Remember Zika in 2016? And now this. So we have to keep that in perspective as well. So we will do that analysis of things that went wrong, but for now, we really need to focus on saving lives.
And talking about the disease itself, or the virus itself, the issue of transmission, obviously, understanding of it is evolving. Initially, we heard perhaps airborne transmission possibilities of 6 feet and then 13 feet. Some recent articles have said there are concerns that medical workers, doctors, nurses, technicians might be tracking it on their feet just from the particles, the virus, falling on the floor, and be able to track it outside of a hospital. What do we currently believe to be true about the nature of transmission, besides the fact that it's extremely, extremely virulent and able to transmit seemingly easily? And is also part of the problem that many of the people who are probably transmitting it are people who are asymptomatic and have no idea that they're sick.
Yeah, a lot to unpack there. So a few things. First, this virus, which we're now calling SARS-2. So there was SARS-1 in 2003, there was MERS, which from the Middle East, and now SARS-2, has some similarities to the other serious coronavirus pandemics, epidemics. Among them is they disproportionately affected healthcare workers. So for SARS-1, MERS, and now this, you saw terrible outbreaks in hospital affecting large numbers of healthcare providers. And that's been true of all three, and it's true of this one. So the CDC just came out yesterday, Centers for Disease Control. So far, they've identified at least 9,000 healthcare workers in the U.S. have been affected with this virus. And we could have predicted that based on SARS-1 and MERS and what the experience that we saw with COVID-19 in China. By the way, in case there's lack of clarity, when I sometimes use COVID and SARS-2 interchangeably. In fact, COVID-19 is the name of the disease, and SARS-2 the name of the virus, just like we had AIDS and HIV. COVID and SARS-2. So in that sense, it went by the same playbook as SARS and MERS. The differences are, although overall it was had a lower case fatality rate than SARS-1 or MERS, it had this weird duality to it of a cohort of people, and we'll talk about those getting very sick and in the ICU, but all of these people walking around transmitting the virus and being asymptomatic. And that we hadn't seen before. In fact, I remember when that was first reported by a group of Germans. The Chinese had reported, then the Germans reported it. And I remember a lot of public health leaders in this country said, I don't believe it. It's not possible. It was possible in the sense that for measles, for instance, when you get symptomatic with measles, towards the end of the incubation period, the day or two before you get sick, it's well known you could transmit measles. So that wasn't shocking. What was shocking is the fact that there was all these people who never showed symptoms transmitting it. And we don't know the real number, whether some are saying 18%, others up to 50%. But boy, that's what makes this thing so complicated to control, and why there's that urgency for a vaccine. Because by having all those people without symptoms, it adds to the transmissibility. And when we use a value called, and you've probably seen this on TV now, because everybody's home and watching a fair bit of television about the virus, you've seen this value called the reproductive number, or R sub 0, and it refers to the number of people who are infected if the single individual has the virus. So this extreme example, Ebola, which is not very contagious at all, and has a reproductive number of between 1 or 2. It means unless you're taking care of a dead or dying Ebola patient, you're not going to get Ebola. Measles is the other extreme. It's one of the most highly contagious, between 12 and 18. And this virus, we always knew was more contagious than Ebola, or even more contagious than seasonal flu, which is around 1 or 2 as well. Original numbers are up to 4, but now new estimates based on all the people without symptoms and all the hospital transmission, some are putting it as high as 15.
Wow.
It's going to wind up going that high, but it's still very transmissible, and that's why you're seeing these terrible epidemics especially in institutional settings. So the prisons, county jails are getting hit very hard. So right now, the largest single focused outbreak in the United States has been the Cook County Jail. I think 400 or 500 people have gotten infected in the Cook County Jail, and we could talk about the implications of that. Also, nursing homes getting devastated because of the unique institutional nature, cruise ships again. So wherever you confine a large number of people in a crowded space, that virus rips through. And the nursing homes are especially devastating because we know one of the groups that are at risk of highest mortality are older individuals over the age of 65 or 70. And early on in this epidemic in the U.S., we had our first devastating epidemic was in Kirkland, Washington, a nursing home, and I think 25 were killed. And I didn't see the reaction. I didn't see the sense of urgency coming out. So I was invited to the House Science Committee, Science and Space and Technology, and to raise awareness. And I've done this a few times now over the last few weeks. I've sometimes said things which I know are deliberately provocative, and I do it not just to hear myself talk, but to get people to care about this issue. So as I was saying it at the House Science Committee, I knew it was going to be on TV that night, and I used this term, the angel of death. This virus is going to be the angel of death that goes through nursing homes. And it worked. It really got attention. And I've had to do this a few times around raising awareness about healthcare workers or the importance of convalescent therapy. And it's nice things to be able to use my voice to raise attention to certain key issues that I feel are gap areas that everyone's kind of sort of looking at but not really paying attention to. And I've been able to use my voice a few times to make a difference, which is a good feeling.
Well, yeah, thank you for doing that. I think that awareness is crucial for us as a nation and beyond, really. I realize, again, it's something we may not know the answer to, but do we know yet why, obviously those who perhaps are elderly or with weaker immune systems or pre-existing conditions, they would, obviously have more difficulty dealing with the virus. But, for the large numbers of people who are infected, as you mentioned, a large number are asymptomatic with no symptoms. Many people have mild symptoms that are probably so mild they may never even see their doctor, so they're not counted as an additional case. But then there are, a smaller percentage that get a severe infection, or their body creates a severe reaction to it. Do we know yet why that is, especially maybe with people who don't have pre-existing conditions? Is it sometimes that it's individuals' immune systems perhaps overreacting to the virus, or why is it that there's such a wide variety in the reaction to the virus?
Well, we don't know. You're right. We are seeing certain groups that have higher mortality rates, and here they are: individuals over 65 and 70, maybe as high as 10 to 15% mortality. So those are groups we have to protect, especially in our nursing homes, our assisted care facilities. That's we don't really understand why. But by the way, the original SARS-1 did the same thing. It caused 10% mortality overall, but 50% mortality among older individuals.
Wow.
Another group are those with underlying diabetes and hypertension. And that link is very important, especially when we look at the health disparity dimension of COVID-19. So we're seeing high case fatality rates among African American and Hispanic populations. Well, we know definitely about African American populations. The Hispanic populations, I think, will turn out to be true as well, but we don't know that for sure. And I think a lot of that is linked to the high rates of diabetes, hypertension, and renal disease, which are risk factors. And then healthcare workers are getting sicker than you would expect based on age. And again, we don't know why. We saw this in China, and I think we'll probably see this. We saw it in Europe as well. We'll see it in the US. So just looking at the age alone, you wouldn't expect that high a mortality, but it is higher. And maybe that's due to being exposed to a greater inoculum of virus. And then the other thing that's different from Europe and the US compared to China is we're seeing a higher percentage of young people get very sick than we saw in China. So there was an early report coming out of the Centers for Disease Control finding that about a fourth or a third of seriously ill people in the hospital were under the age of 40. So this business that young adults are only going to social distance themselves to protect grandma and grandpa, it's not holding. They're getting pretty sick as well. So we don't know the exact basis of the difference. And then there's this curious paradox that young children and adolescents overall handle the virus pretty well. The one exception we saw in China was about 10% of the infants were getting sick. So that was the one exception to that. But it's not clear if we're going to be seeing that in the US or not. So again, brand new virus pathogen, and always the caveat about this news beginning, what we're saying now may look very different a few months from now or even a week from now. I mean, I look back at the things that I said about this virus and this epidemic back in January, February, and it's sort of cringeworthy. They said, "Oh, I can't believe I said that," and I'll probably do that again. So that's
we'll have you back for part two.
Yeah, I mean, that's what new virus pathogens do. They set you up to make you look stupid, and you have to have some humility about the things you say, because there is these things change. And we're in a new era now where we have a level of science and technology to apply to new pathogens that we never thought were possible before. And so the learning curve is so steep, but along the way, we're going to be making some mistakes as well.
Thank you. And after this, I want to turn to the longer term view and our options maybe with regards to vaccines and preparedness for future pandemics. But just for the immediate cases now, some of the treatments people may have heard about in the news, such as chloroquine. I think just recently, one or two of the studies that were set on it were canceled because of concerns that might cause fatal heart conditions. People might have heard about antibody transfusions, even if they could only last for maybe 6 or 8 weeks. That'd be very helpful to frontline medical workers. Can you talk about what we know now about how best to treat the disease now?
So we're going to have an array of new technologies being rolled out, and I always like to use this to plug why, as American taxpayer, you've been supporting the NIH all these years, National Institutes of Health, which is funded about $36 billion a year. It's a great investment, and one of the ways that's paying off are all the new technologies being rolled out, but they'll come out in stages. And so the way I like to sort of present it as a hierarchy, the ones that take the longest and the highest risk ones and the ones that also have the biggest payoff, of course, are vaccines. And we have a timeline of a year to 18 months. I have to say that's actually an optimistic timeline, and we can talk about that. So that's the furthest out. Next out are going to be new small molecule drugs used to treat patients. Then the nearer term one are drugs that are already out there that are being used for one purpose or another that could be repurposed potentially for this virus, and that's where the hydroxychloroquine and ivermectin come along. And then the convalescent antibody therapy, which we have now ready to go. So let me talk about each very quickly. The convalescent antibody therapy was shown to work for the original SARS, and it's basically taking blood from people who've been infected, recovered from the virus, develop antibodies, and in some cases there's evidence that having antibodies makes you immune, and exactly what the threshold is in terms of the level of antibody you need to show immunity is not clear, but now there's a study showing that in non-human primates and rhesus macaques, they were unable to reinfect rhesus macaques that have antibody. The idea is you take the antibody out, and you could do this in the transfusion unit in a university medical center, give the patient back their red blood cells, take their plasma, and use it as a treatment for ill patients, provided you give it early enough. And there's some suggestion that it could be given in smaller doses to frontline healthcare workers or first responders. And you're right, the antibodies don't last forever. They last for a few weeks, but you could keep giving it potentially to keep them protected. So all of those things are being evaluated now by the Food and Drug Administration. And I remember back on March 13th, it was actually a Friday the 13th, that's when I first really pushed out this idea. And not that I was doing it myself, but I had called some of the thought leaders on this to say, hey, I know you're trying to do this. Let me give it a voice, because they were getting a lot of frustration getting anybody to care about this idea. And so I like Churchill's comment about who once said, I was not the lion, but it fell to me to give the lion's roar. And that was for that convalescent antibody therapy. So it's not this, but
that was you're growing your beard for your mane.
Right, exactly. And then we're hearing about chloroquine, and I know the White House and the president in particular has been pushing that, and it's based on some small studies done by a French group out of Marseille, a colleague that I've known for a long time, Didier Raoult, and they're small studies, and well, there's two things going for it. One, in the test tube, it seems to have antiviral activity. In small studies, it seemed to have some effect, but that's where we are with influenza. So the same was proposed for influenza a decade ago, and it never really panned out. So I was really trying not to throw cold water on it, because you never know for sure, but basically trying to downplay it, saying, yeah, it's looking, I know it looks promising, but we saw this for flu, let's see what happens. As this continues, I'm becoming less and less optimistic about chloroquine or hydroxychloroquine. And then a study just came out of the Amazon region in Brazil, in Manaus, where if you use the high dose chloroquine, that starts causing heart arrhythmias, and they actually had to stop the study. So I'm certainly less than 50-50 on it now, and I think it may not pan out. But there's other repurposed medicines that are rapidly being assessed. And we will have some new drugs out there. There's no question about it. I just can't tell you which ones they're going to be yet.
And before we just kind of, one more question, and we'll discuss the issue of vaccines and then turn it to audience questions. But can you talk to people who may have heard about the concept of a second wave? Maybe briefly explain what that is, why it would happen, and say, would you expect it to say hit the United States or other parts of the world?
Well, the way this is going to work as follows. There's a lot of pressure now, and you hear the president talking about it, and some of the governors saying, look, we can't keep our economy shut down forever. We have to get people back to work. And I've been saying we need to hold off a few more weeks. And I base this on, and again, they're based on epidemiologic models, and there's a bunch of different ones out there, but the one that all of the people listening to this can look at themselves, and this is why I like it, is because it's so transparent. You can go to healthdata.org. This is the website of the Institute for Health Metrics. an evaluation out of the University of Washington. This is supported by the Gates Foundation. They have some great models, and it shows how the peak is starting to come down now very slowly in New York and New Jersey. We're a bit behind in Texas. It's not going to come down it's not going to peak till May 1st in terms of cases and deaths, but it assumes that we're going to be doing social distancing. And the other thing that's nice about the website is it's one of the few that breaks it down by state. It's not perfect because they do one model for the state of Texas, and as everybody listening to this knows, what goes on in Houston may not be the same as what goes on in Lubbock or Amarillo or El Paso. We're a big state, but at least it tries to break it down by state so that by June, I think people can feel a little safer going out and about in the community. And then the question is, what happens then? What kind of program will be put in place for rigorous testing? Because there's still going to be the risk there. And then, as you asked, will it come back? And my colleague, Mark Lipsitch, who's a epidemiology professor at Harvard School of Public Health, put out a paper in Science Magazine. His team put out a paper in Science Magazine yesterday showing that the prediction might be that this virus peaks in yearly waves. Flu in the Northern Hemisphere, influenza often peaks in January, February every year, and there's a possibility that this coronavirus, COVID-19, will do the same. And so we could have this around for a while, for a few years in regular peaks, so that even if we can relax some of the social distancing as we move into the summer, I've been saying we're going to have to be mindful and have some situational awareness and recognize that we may have to again implement aggressive social distancing in January and February of 2021 and then 2022, and then for a few years after that. And are we going to be willing to do that as a nation? Some of the governors right now are even digging their heels in about doing this now, even with all the deaths in New York and New Jersey. Will there be the appetite from the business community or the political community to do this in January? Or the opposite, you have so many people now that are with PTSD who are just absolutely terrified to go out into the workplace, worried they're going to get this virus, and how are we going to manage that? So there's going to be a lot of complexities. I was just on with Nicole Wallace on MSNBC this afternoon, and then with Katie Tour the day before, basically going through this, all of the complexities of the different types of diagnostic tests and how we're going to manage the mental health trauma and how we're going to do the communications. This is going to be a carefully orchestrated dance. And I made the suggestion today on MSNBC that maybe what we should do is, before we roll a plan out for the whole country, let's do this as a pilot program for a couple of states and see how it all works and troubleshoot it, and then we can move that forward. And we'll see if people like that idea or not.
Okay, and then just moving on, just because I know you have another meeting always, whether on television or elsewhere. Could you briefly talk about the work you and your colleagues, right here at the Texas Medical Center, the Baylor College of Medicine, Texas Children's Hospital, what work you all are doing on a vaccine for SARS-2 or COVID, the disease for COVID-19, and I guess also maybe is it far too early to tell if a vaccine is developed? Is this a vaccine like, say, measles or smallpox that seems to grant a lifetime of immunity, or maybe the virus is changing that every year you have to have a new vaccine like the flu?
So there are about a dozen different vaccines that are going to start moving into clinical trials, and hopefully ours will be one. One of the advantages of ours, it's a older, more established technology, the same one used to make the hepatitis B vaccine, and that has a particular advantage because it could be used not only in the US and Europe, but actually could be the first global health COVID-19 vaccine because it's a technology, because other countries make hepatitis B vaccine, therefore they have the skills to make our vaccine, we think. So we think this could be one of the first vaccines potentially rolled out for India, let's say, or the Indian subcontinent, or maybe even Brazil. in places like that. So we're pretty excited about that. So one of the struggles that we're having is, though, you wouldn't think I'd have trouble raising money at this point, but we've gotten some support from the NIH, and we're trying to get around $5 to $6 million, and we're about less than a third of the way there, unfortunately. And so we have put up if you want to go to TexasChildren'sVaccines.org, TexasChildren'sVaccines.org, one word. We could certainly use the support, but how quickly things will go, we don't know. I mean, the record is 4 years to make a vaccine. That's probably the mumps or the Ebola vaccine. Can we break all records and do this? Well, we have. The U.S. government is clearly trying to create something along the lines of a Manhattan Project for this, using the first nuclear bomb metaphor. And we're trying. That's our charge. And I'm waking up every morning at 4 or 5 a.m. and the first thing I do is I look at my text that morning in emails, and there's already a text from Dr. Batazzi, Mary Elena Batazzi, my co-partner for the last 20 years, and she got up at 3:30 in the morning. So other of us are sleeping. We're doing conference calls late at night, and it's all about what we need to do for this international effort to get the vaccine into clinical trials, number one, then raising the money. And in between, I'm getting out of my bow tie and button-down shirt and putting on the sweatshirt and doing all the teleconferences. And you don't know this, but I have sweatpants on right now, and looking.
I'm wearing shorts.
So every time you see me talking to the nation, I've got sweatpants and my cat on the other side of this sleeping, and sometimes going into the lab where we're not supposed to be in the labs because of the social distancing, but we have permission for a small group of us of our incredibly dedicated scientists because of the unique nature of this COVID-19 vaccine. It's this partnership between Baylor College of Medicine, our National School of Tropical Medicine, and Texas Children's Hospital. But we also have some other important partners. So the Galveston National Lab is where they actually have the virus, so that's where we can test whether these vaccines actually protect against the virus, laboratory animal models. We work at the New York Blood Center that has got this amazing coronavirus virology group. And then we actually do our manufacturing with Walter Reed Army Institute of Research. So the U.S. military has been our partner for 20 years. And not many people realize how important the U.S. military has been to vaccines. So they were the first to make the malaria vaccine, the meningococcal, and some of these others. And we're partnering with them. So we have a great partnership with the U.S. military. Actually, all my mentors came out of the military, out of Walter Reed Army Institute of Research.
And I will say, unsolicited, I've known Dr. Hotez for over 8 years. I know a lot of his great colleagues. I've been to their facilities at various places in the medical center. They truly do incredible work. So I say that unsolicited and I suppose on the spur of the moment. Now I know, because we're basically almost out of time, but maybe just very quickly, Dr. Hotez, if you could give just a few quick answers to some of our audience questions. Maybe I'll start with a question from one of our students, Lynn from First Baptist Christian Academy. And again, I'd like to mention to all of our middle school and high school students, we'll be hosting our Global Scholars Academy in July. We're hoping and presuming by then people will be able to meet in person and get a chance to meet with former CIA and FBI and DEA agents, great scientific and medical nonprofit experts, like Dr. Hotez. I'm not signing you up yet, but business leaders, journalists, a big variety of people, and diplomats as well. One of the questions Lynn asks is, why is it that some people are tested the virus and test negative, and then later on down the line, 2 or 3 weeks later, test positive? Is that they've been reinfected, or the volume of the vaccine in the bloodstream was not high enough at the time? I mean, not the vaccine, the virus was not high enough at the time. Why is that?
Yeah, so she's probably referring to, well, there's different kinds of test. There's the antibody test to see if you've been exposed to the virus. But the other, I think the test she's referring to is the PCR test that looks for the virus or evidence of the virus RNA from nasopharyngeal swabs, meaning the nose, the mouth, the throat. I think the problem there, this is actually not unusual to COVID-19. It's true of a lot of respiratory viruses. You get inconsistent sampling. So, and sometimes the amount of virus in your body is not very high. So it's not unusual, for instance, for you to be, even though you think you're sick, you're negative, all of a sudden you become positive. But then sometimes you can have a waxing and waning course and the virus load goes up or down and the test is not sensitive enough, so it registers negative. And then it becomes positive again. And some people think because it became positive again, you got reinfected. And it's possible that's the case, but most of us think that has to do with the waxing and waning course or the sampling more than anything else.
Okay, and then another one of our great members, Fadi Jakob, who's also, a lot of you might know him as one of our co-MCs for WorldQuest. He asked, when will the antibody test be available in Houston and maybe just more broadly across the United States?
Yeah, good question. I don't know the answer to that. That would be a good one for the leaders of the Houston Health Department, David Pearce, or Harris County, or Mayor Shaw. Two of the best health departments in the country. And I know they're working hard to roll that out. The other thing that's happening is just for the virus test, there's a lot of effort now to try to expand testing in some of the low-income neighborhoods, because if you looked at what happened in New Orleans, they got hit very hard because of the African-American community and especially, but also the Hispanic community, the underlying rates of chronic illness, high case fatality rates. For a while, New Orleans had the highest case fatality rate in the country. And there's a big worry that could happen in Houston, some of the poor neighborhoods. So Mayor Turner, County Judge Hidalgo, the members of the Texas delegation, Sheila Jackson Lee and Dan Crenshaw, and the list goes on. Congresswoman Garcia. Now I'm in a trap because then when you start mentioning some, you got to mention all of them. But they're all on board. Have really been emphasizing, doubling down on that testing in some of the low-income neighborhoods because we're very worried about that.
Okay, and just two last questions. I know aren't necessarily short, but just maybe be as brief as you can. Another great member, Joseph Watson, asks, what would it take and how can we work to build, if it's possible, herd immunity, especially before a vaccine can be developed?
Well, it depends on the models you look at. Some people say to develop true herd immunity, it's 60 to 70% of the population. And that's what the original plan of the UK government was. Just let's get everyone herd immunity, then we'll be done with it. Until somebody pointed out the inconvenient truth, that would mean the death of 500,000 Brits. So that wasn't going to work. But 60 to 70% may be the goal. So where are we at now? Well, I don't know. The problem is that there's been so many issues with the testing that almost certainly the number is larger than 500,000 or 600,000 is currently reported. The rule of thumb, my unscientific rule of thumb, is for every death, there's 1,000 infected individuals. And now I'm saying this to a lot of people. We do not have strong evidence for that at all. It's just kind of my working hunch that I would look at. And if that's the case, then if there's roughly 20, 30,000 deaths right now in the United States, that means 20 to 30 million people are infected across the country. That sounds like a lot, but that's less than 10% of the population. So we have a ways to go before we get to herd immunity.
Okay, just last, really another good question from our audience. Dr. Paul Hodgkins asks, what will it take to keep reducing the number of new cases? Or is there anything extra we should be doing?
Well, the social distancing is the most proven one that we have so far, and that's going to be very important. And also, if people wear masks, not because it'll prevent you from getting infected, but it may reduce some of the transmission for people who are without symptoms walking around the community. So that will likely help. And I think when you see social distancing, as that eases up, you're going to see a lot of requests for people with masks. So unfortunately, that's all we really have right now. And we don't have the adequate technologies for doing the prevention, but it's going to be a lot of testing and also a lot of contact tracing. And contact tracing means if find someone's infected, to talk to all of the people they're talking to and get them to quarantine. It's very labor intensive. And, whether we can do it or not, we'll have to see. I mean, if you talk to people like Umir Shah at Harris County, he'll tell you, look, just for the handful of measles cases that we had to track down last year, it was all hands on deck. How are you going to do this with thousands of people with COVID-19? Hiring an army of volunteers or hiring an army of people to take this on, we'll have to see.
Well, thank you very much, Dr. Hotez. Always great to have you again, as always. And for those of you watching at home, if you want to let your others, family or friends know, this will be available on YouTube in a matter of hours. We invite you again to subscribe to our YouTube channel. And please join us next week, next Wednesday on April 22nd, when we host another live live Zoom webinar with former acting ambassador, U.S. ambassador to China, David Rank, on a program on China, China's economy, the Communist Party, and relations with the United States and the rest of the world amidst the COVID-19 era. I thank you so much, Dr. Hotez, for taking the time, and I turn it over to our CEO, Marianne Maldonado.
Thanks so much, and good luck to you and your family.
Thank you.
Thank you, Dr. Hotez and Ronan. It's been a pleasure having you, and thanks to everyone who's tuned in. If you learned something new today, ask that you like this channel and be sure to hit the red button and click to subscribe to all of our programs come into your inbox. And until next time, we hope you'll stay connected with the World Affairs Council of Greater Houston. Remember, keep informed, keep healthy, keep safe. See you next time. Bye-bye.
Thank you.